multiple small dispersed from the knee region to the buttocks region, and if you see interspread between the pustules, there is a diffuse erythematous rash. So with this starting, the diagnosis which we kept for the child was term AGA, girl child, well baby, transient toxic erythema of newborn. So coming to the classification, neonatal dermatosis falls under one of these classifications. Either it's a transient lesions or birthmarks or infections, infestations, genodermatosis or neurocutaneous. And in the transient lesions, we have these 5, which are toxic erythema of newborn, transient neonatal pustulosis melanosis, neonatal cephalic pustulosis, acropustulosis of infancy, and malaria. We'll just see how to approach this. Like by the end of this class, every one of us, we'll make sure that we will understand or we'll know how to approach these problems and come to a final conclusion. So how to approach this problem of this rash which appears in the neonatal period? First of all, the first question which should come to our mind is status of the baby, day of onset, distribution of the primary lesion, nature of the lesion, erythema around the lesion, whether generalized erythema is present or not, or there is a residual lesion after the rash has disappeared. With these set of questions, we can answer or we can come to a conclusion or a diagnosis. First of all, for starters, what is a papule? What is a pustule? Cutoff values are from 0.5 centimeter to 1 centimeter, but the crux is like a papule is an elevated and it is reddish, whereas pustule it is whitish. And with this basics, we'll move further. Based upon the age of onset, these 5 lesions, they have a very distinct and separate age of onsets. Transient neonatal pustulosis is present since birth, whereas a toxic erythema of neonatorum, which is our index case, presents somewhere around day 3. And malaria, which we'll discuss later on, it will present at the end of 2nd week, and neonatal cephalic pustulosis at the end of 3rd week, and acral pustulosis of infancy, which presents after 1 month of age. So with this first question, the age of the baby, we can broadly classify. Though there is an overlap, we can broadly classify or come to 1-2 conclusions. And if you see the pustulosis, if the baby should be systemically healthy, and if the pustulosis is a generalized one, and it's present on day 1, and generalized erythema between the pustules is absent, then the diagnosis would be a transient neonatal pustular melanosis. Whereas if the pustules are present and they appear on day 3 and generalized erythema is present between the lesions, as in our case, then it will become a toxic erythema neonatorum. And localized lesions, the other 3 we will see into them later on. First of all, toxic erythema of newborn, it's a benign transient condition. Etiology is unknown. Blotchy macular erythema. You notice this like diffuse erythema between the lesions. If you once see the child, you will be like, first time if someone sees the child, we will be afraid that what has happened to this baby. And it is present over the trunk, face and proximal limbs, and most importantly, palms and soles are failed. And severe cases, there can be severe irritability in the baby. Parents complain saying that child is very irritable due to urticarial papules, which arise within the erythematous areas and surmounted with small pustules. So see this one. These are the pustules. And between the pustules, there is an erythema. So this generalized erythema is spread all over the region wherever the pustules are extending. And histopathologically also, they both are different entities. And most importantly, they are not present at birth, fades away at 3 to 7 days, and systemic symptoms are absent. And smear is negative. A smear shows eosinophils, and there is no infection growing on. So treatment or advice which we give is reassurance. We tell the parents that don't worry, these rashes fade away. Second, the closest mimicker or the rash which appears during that period of time is transient neonatal pustular melanosis. It's an idiopathic pustular eruption that heals with a brown pigmentation, hence the name melanosis. And it is present since birth, and these are 1 to 3 centimeter flaccid and with no surrounding erythema, and they are present particularly in chin region or axilla. See the image here. If you notice the first image, there is no redness in between the lesions, They're discrete small pustular lesions. So what happened to these pustules? These pustules later on form a brown crusting, colority of scales, and hyperpigmentation. So if you see, these are the pustular stage. Later on, they have a brown crusting, and they form hyperpigmentation. And these hyperpigmentation, they can extend up till, they can be present up till 3 months of age, or occasionally till years, initial 1 to 2 years of age. And investigation, when an histopath done, it is predominantly neutrophils, unlike the other one, which is eosinophils. And bacterial culture doesn't grow anything here also. So the treatment advice which we give is self-resolving and reassurance. And we have so far gone through the generalized part. Now we'll go through the localized part. And neonatal cephalic pustulosis. As we are discussing the localized part, you see the name itself tells it is cephalic. It is restricted only to the head or the face region. It presents around 3 weeks, associated with Malthusia furfur and erythematous papillopustular lesions. If you see this erythematous papillopustular lesions surrounded by an erythematous halo. This halo which is present only, it is present around the pustules and not between the two pustules. And sites are, as mentioned, over the face or head region, and comedones are absent. And treatment is self-resolving and reassurance. They heal by 1 to 3 months of age without any scarring, unlike the previous one. Acropustulosis of infancy, it presents around, as the word says, infancy, around after 1 month of age, and they are discrete erythematous papules. Later on they crust and they form vesicular pustular regions. This is the time when the parents come, because at that time maximum irritability will be present, and later on they form a crust. They're intensely pruritic, and they're present only in the palms and soles. So, and histopathology also shows neutrophils. And for this case, it is a topical corticosteroids are the treatment. We advise the child to be sent to dermatological OPDs. And the last one of the localized one is malaria. It is due to simple blockade of the eccrine sweat glands. And there are 2 types, crystallina and rubra. The one which we see in newborn period is crystallina. These are the images of the crystallina. And they are also self-resolving. And whereas rubra, it is the prickly pear which we see in children during the summer seasons is the malaria rubra. And for that talcum powder or occasionally topical steroids might be necessary. When to think beyond the pustular lesions, when is it not a simple pustular lesions and something is much beyond. So these are the things which we check when a newborn comes to us with pustulosis. First of all, there should be no systemic signs. It should be baby should be a well baby, and otherwise hepatosplenomegaly, microcephaly, and chorioretinitis, think of torch. And features of Down syndrome are present, and same hepatosplenomegaly, high TLC count, then neonatal pustulosis of transient myeloproliferative disorder. Whereas an older child complaining of pain or irritability, cry with lymph node enlargement, hepatosplenomegaly, LCH should be considered. Pneumonia and hepatitis, it's neonatal varicella, and dermatological scarring, and eye involvement in the form of chorioretinitis, and skeletal in the form of osteitis. If these are present, then it is congenital varicella syndrome. So treatment which we gave for this child was reassurance, and we ensured that exclusive breastfeeding is happening, and immunization as advised, and supplements, and the next visit was 6 weeks. Coming to the second case, a baby of R, 45 days male child, presented to OPD. He's a resident of Chandigarh, presented to OPD, and he came with complaints of mass at the umbilical region and discharge from the umbilicus for past 2 days. Nature of the discharge was watery, not as with any pus, foul smelling, and no bleeding was noticed. No redness around the umbilicus, not as with any irritability, refusal to feed, or lethargy. No history of any feeding or feeding difficulties or latching, and child was sucking well. Antenatal history was fairly well, and had a smooth perinatal transition, and was discharged on day 2, and accepting breast feeds well and passing stool and urine. So on examination, child was pink, CFT was 2 seconds, no icterus. Local examination showed pale pink plushy mass in the umbilical region with serious discharge and no erythema noticed around the umbilical region. Systemic examination was normal. Our diagnosis was umbilical granuloma. Umbilical granuloma is an overgrowth of the tissue during the healing process of the umbilicus. It's a normal thing. It's like the epithelialization has not finished over the umbilical region. Usually by end of first week, the umbilical dries out, and by end of 15 days, it falls off. And If after falling out, occasionally small fleshy mass might be visible, but if it is persistent and if it shows serious discharge, that with these complaints, usually parents come to us, and it's a like a incomplete physiological process where the epithelialization, which starts from here and covers over this, has not been finished. Small amounts of clear or yellow fluid are seen, most commonly seen in the first few weeks of life. Treatment is chemical cauterization with common salt or silver nitrate. Chemical cauterization with common salt, silver nitrate, and copper sulfate are the modalities which are available. If you notice, like after applying the common salt, within few applications, this epithelialization starts, and it starts to hyperpigment, like the color starts to change. It is that time when that the epithelialization has started. And side effect of silver nitrate being used is like they can have chemical burns around the umbilical region and making it an open wound, causing chances for the umbilical infection to happen or ampulitis to happen. And this is the surgical modality, which is suturing. The differential is an umbilical polyp, which is a very, very rare entity, remnant of white low intestinal duct, and it's a firm, bright mass, which is either an intestinal tract or a urinary tract mucosa. So mucoid secretion is usually seen, unlike there, which is a serous secretion, and fecal material is maybe seen at the opening of the lesion. And treatment for this, if you see this image, this is an umbilical polyp where it is a remnant of the white low intestinal duct and an ectopic intestinal tissue sitting over this one, which mimics the umbilical granuloma. Most often it is a protruded mass, and though both of them can mimic each other, it's a bright red protruding, and mucoid and fecal matter are seen. So we will take a few minutes to see what is the routine umbilical care which we have to advise to parents when we see such a child.
So please be fast.
Last set. Umbilical cord should be kept clean and dry. Caretaker's hand should be washed. Stump if it's soiled. Mild soap and dried through soft and clean cloth. And nothing should be applied over the cord stump. And diaper should be below the stump, and no bandage should be applied. And danger signs for this umbilical granuloma would be a rash around the region, or a granuloma being bleeded, foul-smelling discharge, swollen and red, change in character of the secretion. And this is an image of the ampulitis. If at all an umbilical sepsis has happened, beware. This is an neonatal emergency because highly risk of IV septicemia to happen. And treatment we gave for this was reassurance, and keep the umbilical region dry, clean with fresh, clean dry cloth, and apply a pinch of salt over the umbilical region for 10 minutes twice daily for 5 days. And exclusive breastfeeding, vaccination, and immunization, and next visit.
Okay.